Last week, I spoke with Linda Villarosa, professor and journalist in residence at the City University of New York and a New York Times bestselling author of Under the Skin, a book about some of the history behind racial disparity in healthcare and outcomes. We delved into the role that slavery played in originating some of the health myths about black bodies that we're still plagued with in modern healthcare. Today, we'll hear from someone who went through a health crisis that has undertones of racial inequity, from the basic understanding of how the disease differs in various races to how to diagnose it. One thing to be aware of as you listen to today's story is that for the longest time in medicine, research studies were conducted solely on white men. If you were a person of color or a woman, either everyone just assumed that the health outcomes would apply to you in the same way, or they didn't care. But as the medical community has been learning for a while now, that's not the case. Certain diseases look different when they're starting, or they grow in different parts of the body, or even call for different kinds of screening and treatment, depending on your gender and your race and your ethnicity. In 2020, some really smart researchers reviewed a lot of the big studies previously done on prostate cancer to see what races were included in those studies. Of the 72 studies that they looked at, 58 of them actually mentioned what race the participants were. Of those 58 studies, 96% were done only on Caucasian men. This undermines our efforts to understand how a disease might affect, say, a black man differently than a white man. This is Doctor Patient, a podcast that examines all the aspects of the patient-provider relationship. I'm your host, Heather Johnston, MD, a real-life doctor and patient. My guest today is Michael Tyler, a freelance writer, speaker, and author of award-winning children's books, including his first, The Skin You Live In, which I read to my kids when they were little. It's a book about kids' social acceptance of different cultures. He has since authored 3 more wonderful children's books, Mirror Face, The Smallest Dot of a Dot, and his most recent New York Times bestseller, Girls of the World. Michael is a wonderfully contemplative guy, and I asked him onto the podcast to talk about his experience with a recent health scare. Michael, thanks for joining me in the conversation today.
It's an absolute pleasure to be here. Thank you.
You're a Chicago native, right?
Born and bred, Southside, Chatham is the neighborhood I grew up in, yeah.
All right, tell me a little bit about how that was.
Chatham was fine. When I was growing up, Chatham was probably one of the most stable African-American neighborhoods in the entire city. It was high employment in the neighborhood. There were a lot of police officers and firemen who lived in the neighborhoods, some professionals, lawyers, and the like. So it was a very stable middle-class neighborhood. And I have nothing but fond memories about growing up in Chatham. Everything else around me looked like a war zone, but
yeah.
But Chatham was a safe place to be.
You had some health problems over the pandemic that I want to jump into, but before we get into exactly what happened, I guess I wanted to get a little bit of background about you and health and the topic of being a black man in the U.S.
Okay.
And so some of my questions are, when you were growing up, did your family talk openly about health and health disparities and what it meant to be, black and looking for health in Chicago?
That's an interesting question. We openly discussed health in terms of the ailments and afflictions that were presenting in our family. Like high blood pressure was very common, diabetes was common, cancer was common. Because even as a child growing up, I was fully aware of my relatives who were suffering from certain diseases, ailments, and afflictions. But we didn't really discuss disparities in healthcare as that issue is now presented and known. What was always present in all facets of life, even healthcare, was that we were going to be treated differently and that we may not have been given the same level of care. We didn't have the same access to facilities or procedures or physicians that somebody else might. But as the issue is now discussed,
you were aware of that as a kid?
I was aware of that as a kid because that was instruction for all aspects of life. I go to a grocery store, I was aware of that. I would go on a street corner, I was aware of that. I would go onto a bus, I was aware of that. So that just touched on every facet of my life, is that I had to be aware of that. And I saw it. I mean, I can remember not being able to go to some physicians or some clinics or some hospitals and had to be told that this is where we had to go. I remember that growing up. And so I had firsthand experience with that. But to the extent that that is now present with the many consequences and ramifications that exist today because of healthcare disparity, I wasn't aware of that. That's something that I came to much later in life.
So tell me a little bit about what happened when you got sick over the pandemic.
My entire life, the disease that I was most afraid of, but knew that I was going to get and I was going to be dealing with one day, was prostate cancer, because so many men in my family, both sides, maternal and paternal, had it. My father had it. My two brothers, who are just a year older than I am, identical twins, had it. They had it a year and a half before I did. Uncles, grandfathers, you name it, everybody had it. So I knew that my time was coming. It was just an issue my entire life, but trying to stay healthy enough to postpone it and to do the things I needed to do to detect it. Because prostate cancer is one of the easiest cancers to beat if we can detect it. Any cancer will kill you, but if you can detect it, you have a better chance at it. And so I started that pursuit early on, and was about 4 or 5 years before I was actually diagnosed, started to chart what was going on in my body with respect to prostate health. And there was a steady progression and rise in my PSA numbers. So it got to the point where my physicians, my urologists, decided that this is something, given my family history, that they needed to become more aggressive about, and decided that it was then time to do my first biopsy. And essentially,
how old were you at that time?
This was just 2020. I was 60 years old. This is 2 years ago. Yeah. A little more than 2 years ago. And you mentioned that this happened during the pandemic. I was never afraid that a pandemic was going to kill me, but I thought prostate cancer might. I was not afraid of COVID at all. So, because COVID had been lurking around for 6 decades in my brain, right? And so we did the biopsy, and it showed nothing. And there was no pathology present. And then over the next 3 or 4 months, as I was healing, we kept testing my numbers, and they kept elevating. It was a mystery. Went back in, did another biopsy. Again, no pathology. There's no disease present in the tissue we took out. And then my numbers kept rising again. And as they were trying to figure out why my numbers are rising, attributing it simply to inflammation of the prostate, BPH and all that other stuff, a study came out. And the study came out and revealed that there are 20 biomarkers associated with the prostate gland, but that African American men and Latinx men only present 8. And so there are 12 that are not even showing up for us when we're being tested. Not only that, it showed that the area of the gland in which cancer presents in white men is totally different than the area that it presents for men of color. It's like saying that it presents in the southwest corner for white men and the northeast corner for men of color. So when they're taking tissue samples, they were always taking it from the area that they had most documented. And that area is
the white man's area of the prostate.
The white man's area of the prostate. Exactly.
Weird.
They had not done the Lewis and Clark exploration to the other aspect.
Right.
So,
Lord. Okay.
And so when they discovered that, they immediately called me in, presented me with the data from the research, and said, we think that this is the reason why we're not getting diseased tissue, but we're getting numbers that indicate your disease is present. So we need to go in and do another biopsy. And that was the most extensive one. That was not an office procedure. I had to actually go into the hospital for that one. And when they went in, there it was. There was a tumor. It had already burst through the seal, and the tissue was very diseased. And it was a week later that I was in surgery. It helped with the prostatectomy to remove. And because it had broken the seal, I had to have radiation therapy afterwards for about 15 weeks. But luckily for me, nothing has been present and everything checks out and I seem to be okay. But that was my real experience with understanding what healthcare disparity is about when it comes to its applications towards people of different ethnic, racial groups. Because I was being presented with hard data that said that for the longest time, healthcare had been based upon the physiology and anatomy of white men. And that it had not taken into consideration that it might be different in people of other races and ethnicities. Women have had this problem far longer than men had, because the pharmacology that we live by, the medicines that we take, have all been based upon male physiology. And the biochemistry between men and women is dramatically different. All we got to do is look at one hormone to understand that. And so it struck me doubly so with impact that I was finally faced with dealing with this disease, but that all of my efforts to try to have early detection, all of that vigilance that I applied, because in my mind, the front of my mind, not even the back, I knew that this day was coming, was all for naught because I was undone by my race. I was undone by the fact that I didn't fit into the category that was determining how this disease is detected and treated in all other men. And it was a hard reality for me to go through.
I didn't know that much about prostate cancer. I'm a pediatrician, right? This is not my area of expertise whatsoever. So I did a little digging and reading about it. I actually found a paper from 2014 suggesting very strongly that the location in the prostate where cancer grows in men of color is different than white men, Caucasian men. It is in the anterior part. That's like the forward part of your body instead of in the posterior part, which is the backwards part of your body, the back part. That was in 2014.
Right. Think about it.
It's, I didn't find a ton of studies after that, but then they started popping up, years and years later. But it's just so slow going. It's like there's a Titanic here of how to do research, and especially on people of color. And it's just so difficult to turn the boat to get people to include the right study subjects or even look at stuff like this. I was shocked that study was so old when, you had told me that your doctor, who sounded very, very good and diligent, they didn't seem to know about it until 2020.
Right. And in our discussion, I'm so glad you brought up that you found that study in 2014, because after my urologist became aware of this new study and this data came out, he began to research on his own accord before he talked to me to see if there was anything else out there. And he found that same study in 2014. And my physician is Asian American. And so he sort of felt a different level of personal empathy in talking to me about it, because he's also dealt with disparagement and discrimination and so forth. And so after he gave me the data, he told me about that 2014 study. And so when I said just a few minutes ago, it hit me doubly hard, because when I found out about that 2014 study, I was thinking, wow, between 2014 and 2020, when I was diagnosed and found out, that 6-year span, how many men who look like me didn't get the benefit of that information? How many doctors didn't even know about it? My physician didn't even know about it.
Thousands and thousands, and many still don't know about it.
Yeah. And so how many have lived shorter lives because of it? How many lived more uncomfortable lives because of it?
Yeah.
How many were so adversely impacted in their lifestyle and their relationships because of it? And
It's tragic.
yes. And so the issue of the disparity also must be evaluated from the standpoint of not are we including a broader body or a broader subject group to test on and to get extrapolate information from, but are we valuing those people enough that even when we get the information to pass it on? And so if you look at me and the people that I represent in this culture, in this society, and you give me no value, or you degrade or depreciate my value, then you find no value in my existence. You find no value
Yes.
in my health. You find no value in my contributions, or you at least diminish all of that. So this information can exist, and forget about what money motivations may be behind it, but the information can exist. If you don't simply value my existence as worthy of being informed about what is affecting me, then I'm simply not going to get the information. It's like if I don't care about you, then I don't care what happens to you. And so that is the more insidious aspect of it. That is the more that's the element that to me that it is more enraging of my emotions, is because for our entire existence in this nation, women can say the very same thing, of being second-class citizens as well, is that the consideration has not been given to us because our humanity
Yep.
is not equated in value. That's the main.
Yeah. So let's bring this back down to the doctor-patient relationship.
Part of our indoctrination about health and healthcare is that we're supposed to automatically trust those who know more about this than we do. And so we
That's
trust.
dangerous.
Yeah, it is.
Yes, you should, and you shouldn't.
Right, because what's inherent in that indoctrination is all the social cultural overlay that those doctors themselves receive on a personal level that they're bringing into their profession.
Yeah.
Okay, and so it's a double jeopardy there, because we can't. I don't think anybody has the level of discernment to look at an individual and talk to them and think that that is the comprehensive scope that they're evaluating you with, that it's more caring or that it's more empathetic or there's a greater awareness of it. Because I thought about this question many times myself. I actually haven't answered on one level, because I thought, what if the physician who I've been involved with was a woman?
Mm-hmm.
Would she have had, through her own personal experiences and understanding of healthcare disparities that affected through patriarchy, would she have had a different approach to it?
Mm-hmm.
Because I've had some experiences with female physicians that I found far more beneficial than I've had with male physicians, and I've often wondered if that's the reason why, because they themselves have had to deal with it. And so I ended up, after going through my ordeal, actually meeting and having a conversation with an African-American urologist. And he said that he really wished he had met me sooner and that I had become his patient sooner, because he was aware of that 2014 study. And he had been treating his patients in accordance to the data from that 2014 study. And he said, I could have helped you prevent a lot of what you went through. We could have dealt with this thing differently, because he had seen many patients, men of color, who he was able to help better treat because he was aware of that data. So in part, your answer is yes, it would have helped me.
Yeah. So what are you telling your sons about how to find doctors?
I immediately contacted them both when I was diagnosed. I was actually diagnosed December 17th, 2019. I had the surgery the first week of January. And I said to them, this is in you. This is like the BRCA gene for women. Okay, this is in you. The prostate cancer gene is in you. You need to start paying attention to that when you're in your 30s. You need to understand that there's a certain lifestyle you can live now, respect to diet, nutrition, exercise, that can help you maybe beat the odds or be in better condition and better biochemically fit so that when you do deal with this, it won't be as difficult for you. But to start tracking it as soon as possible, this Black urologist that I spoke to said that he thinks that all African American men should begin to start tracking this when they're 35. And he said one of the main reasons why he advocated for that age is because we have a shorter lifespan in the first place, and we tend to present diseases earlier and sooner. So instead of waiting till you're 45, where other people might start tracking when you're 35. So I told both my sons that. My eldest son is 33, as I mentioned earlier, and he's already lining things up. He's already on track for that. My younger one is 25. He's still pushing that off a little bit. But that's the conversation I had to have with them, that they need to understand that this is a time bomb, and it's going to tick, and it's going to blow up one day. And here's how to go about doing it.
Did you talk to them about what kind of doctor to see and what kind of conversations to have with a doctor that they see?
Yeah, I did, because a lot of what going through an experience like this is what you learn after the fact.
Yeah.
Like I could do a whole class for men on what to do after you've had a prostatectomy that they don't tell you about ahead of time.
I'm sure. That's what patient blogs are for and Facebook groups, because so many people need the information and sometimes it's not given. Yes.
Yeah, it's just not given. Sure. You have to live through it in order to figure out, and you have to figure out what the hacks are so that you can make life a little bit better and a little bit easier for you. So I definitely had conversations with them about what to look for in a doctor who's going to provide that type of care for them, what kind of questions to ask, for them to do their own independent research, for them to not go to a doctor without knowing what their disease was about, without not knowing how it is traditionally cared for and treated, without not knowing what new procedures or pharmacology is available, so that they can introduce all of that into the conversation, because it doesn't often get brought up. If there's a dismissive attitude in the first place because of the social indoctrination that we all live in, then the full scope of evaluating me is not in play. And so they have to compensate for that.
Do you think that patients, especially patients of color, should ask their doctors or their healthcare providers whether they are actually aware of racial health differences and whether they look into it?
I absolutely
as part of their practice model,
I absolutely think they should. As a matter of fact, any new physician that I interact with, because I've had to change doctors over the last 2-3 years. Some of my physicians moved to other cities and I had to find new physicians. That's one of the first things I bring up with them is, what level of awareness are you bringing to this examination and to this evaluation and to this review that's based solely on me being who I am? Not what you were taught in school, not the X's and O's of what you understand a medical problem to be, but based upon how that problem is going to manifest within me. And I've had many physicians and healthcare workers say that that's a question they never have been asked. That's a question they never thought about. And it was something that they were going to now have a develop awareness of, because they realize so much data has come out about how things are affecting people differently, that they need to be more. It's not even an issue of being empathetic about it. It's an issue of being more comprehensive in their understanding of disease and the people that they're treating, to make them better physicians and better able to provide healthcare. Empathy is a part of it, but that's not even what really should be motivating.
I agree 100%. It's not empathy. It's that in your spare time, which doctors have very little of, you need to be making the extra effort to be searching out the information on that topic. You know, the reality is, like, urologists are, just like all other doctors, are exceptionally busy. They're in clinic and in surgery all day. They're on call here and there and on the weekends, and they just don't have a lot of extra time. But in their regular workday, that data may or may not be finding them passively. Like this new study about how prostate cancer presents in African American or Latinx or other men of color, that study might not find its way to them if they're just waiting for it. You need to have somebody who's actively looking up that topic.
I totally agree with you on that, and I would 100% endorse that as a behavioral change, modification of the positions. But I would even say that we need to go more to the root, because we need to go into the medical schools. That needs to be part of how doctors who are coming into the field are actually trained to look for things, to be thinking
100%.
about that, to have that more comprehensive thought process go on. For example, I remember studying pre-med when I was younger and being around a lot of physicians and having lots of conversations. And one of them said that when you go to med school, you're only going to get 1 class hour in nutrition. Throughout the entire 4 years, you only get 1 class hour.
That sounds about right.
And he made that comment because I said in a question session that I had that, to me, everyone argues about what may be the best health insurance available, Aetna, Mutual, or whatever it is. I said, but I'm more interested in health assurance. What's the best health assurance available? And he didn't understand the question when I asked that. He said, I never really heard it apply that way. I said, to me, the best health assurance is what you put in your mouth. Okay, because what you put in your mouth can kill you, or it can keep you alive, or it can give you a better life. And that's when we started having that conversation. So if you can just look at that one subject, nutrition, and realize how little is dealt with in med school, then you can imagine that this other subject isn't even being approached. Okay? Because it should be automatic that nutrition should be part of healthcare considerations. And so I think we need to go into medical schools. We need to alter that curriculum. We need to enhance it. We need to advance it in terms of how doctors are actually looking at the human and not the patient. They're looking at the human and not the condition and not the disease. Because if they look at the human, then they would totally evaluate all the factors that go into consideration for them to make their determinations about how to pursue health with that person.
The medical educator in me is very thrilled that you've brought this up. I think that starting with medical education of young to-be doctors is essential to start making progress in the problem. There was actually a study conducted in 2016 that showed that about 40% of medical students believe at least one myth about Black bodies. Things like Black people's nerve endings are less sensitive than white people's, or white people have larger brains than Black people, or Black people's skin is thicker than white people's. The list goes on and on and on. And what they showed from that study is, about 40% of medical students believed at least one of those. Those medical students are now physicians practicing in the community. And they actually looked at what percentage of them believed one of those myths from year 1, 2, 3, and 4. And still by year 4, I think it was something like 25% still believed one. And then they graduated and became doctors.
Right.
So it shows you that you have to start really right at the pre-med level and at the first year medical student level. And there are lots of great programs blossoming all over the place with this. And I'll be interviewing several people on those topics coming up later in the season. One is a dean at a medical school where they have a great sounding curriculum. One is a medical student who actually took things into her own hands and has designed her own course on racial inequities in health. So that's all forthcoming.
I'm glad to hear
excited.
That's forthcoming. I'm glad to hear that maybe that change is afloat.
Yeah.
That people are beginning to understand that this is essential and necessary.
Yeah.
But what this really shows,
I think it's starting to come to light more, but not enough.
I hope so. That's the very difficult thing about trying to overcome indoctrination. It's so rooted that it prevents you from even having the mental infrastructure to make the consideration in the first place. So that's something that I've wrestled with my entire life. And I've understood that it's not something for me to be angry about, but it's something for me to try to remedy. Because if you only know to turn right, and I introduce an environment to you where everything is a left turn, you might be puzzled because your entire indoctrination has been right turn focused. but I'm going to leave it to your accountability and responsibility that you can open your mind to the possibility of it turning another way. But that's not something that I feel like I can be angry about anymore. I used to be angry about that because I just simply understand that that is the nature of the beast. That is the nature of systemic indoctrination, and that we need to evaluate it, both sides. Everybody needs to evaluate it and understand that this is a systemic indoctrination. This is not a permanent truth. So if we look at it that way, then maybe we can begin to address it properly.
So maybe one solution is that at 5 years old, every single person in the country should be mandated to read The Skin You Live In.
I would only endorse that. Yes.
Me too. Me too.
Let's take it to all the medical schools. Yes.
It's the solution. I'm taking this to all the medical schools. Medical students need to be listening to this podcast. Last question on my end. How has this experience changed you in terms of things you're involved in your life regarding healthcare? I mean, are you involved in anything that you weren't involved in before, like prostate cancer awareness or healthcare reform, or has it motivated you?
I am. I mean, I've reached out to more people I know in the field who are doing work about trying to correct and rectify the impact of disparities in healthcare. People in academia, for example. I try to learn more about it. But I would say the thing that I've done most is I've turned on my megaphone to many people in the African-American community, particularly men, whether it is through a social media post or whether it's at a pharmacy, drugstore or barbershop or restaurant, wherever I am, I'm trying to put that message out there for people to become more aware. And it has invited me into audiences and groups where people have a higher consciousness about this than even I do, and have been more active about it than even I am. So it's definitely activated me and motivated me to try to include this aspect of discrimination into my entire fight against discrimination. It's just become another part of it that I'm trying to deal with as well. Yeah.
Michael, that's all I have for my questions. Is there anything we didn't cover that you wanted to make sure that we got out?
Just one thing. And that one thing is, I'm really happy you brought up the fact that I'm a writer and you mentioned the title of the book. But there's only one thing in my entire life that I brag about. And this is an opportunity for me to do so, is that I make really good cookies.
Yeah, you do. Michael is selling himself short here. He literally makes the best cookies, some of which he calls the Pullman cookies, which his grandfather, who worked as a chef on Pullman train cars for a while, came up with. They absolutely delight my family. If you'd like to learn more about Michael Tyler and his beautiful and relevant books, please visit his website, michaeltylerwrites.com. That's MichaelTylerwrites.com. In terms of prostate cancer, I've added a bunch of links in the show notes to interesting articles about what we've been discussing today. Please check them out if you'd like to learn more. Totally fantastic to talk to you. Thanks for being so open about everything you've gone through and what your thoughts are about it.
I appreciate it because I think that what you're doing is vital. I think that any way that people can get the information out, particularly me talking to someone that I know and trust, I think is a good way to do it, because we can't be silent about this stuff.
No, that is the worst possible thing to do.
Yeah, exactly.
Thanks for listening today. To catch up on more episodes and to get new ones delivered directly to you, subscribe wherever you find your podcasts: Apple, Google, Spotify, iHeartRadio, and more. If you'd like to be a guest or have an idea for an episode, let me know at www.drpatientpodcast.com. That's drpatientpodcast.com. Here's the disclaimer. Even though I am a doctor, I'm not your doctor. These stories, my comments, and all discussion is purely reflection about what's working in the healthcare system and what isn't. Don't use any medical information that you hear in these episodes to diagnose or treat yourself. If you have a question about your health, get in touch with your doctor or local health clinic.